Greeting everyone. I'm Dr. Deependra from Conceptual Orthopedic, and I welcome you all in today's connect session with Vishal sir. And today sir is going to discuss, I think, one of the difficult to understand is spinopelvic parameter and why you have to do this spinopelvic parameter during your total hip replacement surgery. So I think this talk is going to be very interesting and useful to all of you. So without any further delay, I welcome you sir on the board and I request you to start your presentation. Now it's over to you, Dr. Vishal sir.
Good evening, Dr. Dipendra. Good evening, friends, everyone. Am I audible?
Yes, sir. It's loud and clear.
Fine, let me share my screen.
Yes, sir. We can see your PPT.
Okay, all right, fine. So, today I'm talking about one of the most difficult kind of a thing, confusing kind of a thing, that is spinopelvic kinematics. This is the most what do you call it? It's the most difficult part to be understood or comprehended because a lot of things are happening with the uh, what do you call with the parameters. So very difficult to understand, very confusing. So many times you learn, everyone you will get a different views, different scenarios. So let us try to understand. And this question has been started to appear in your exams as well. Okay, but not as often as other parts. But this question starts appearing. I'm expecting this question to be a part of your theory or why was somewhere they'll start asking you about this question. Even if you have finished your MS or DNB, if you're planning for your plasties or any scopy related kind of fellowship programs, this question is, I think I'm expecting this question to be as a part of your entrance exam for your fellowships, and very, very difficult, very confusing to understand. So without further delay, let us start understanding why this topic is so important. Why this topic suddenly came into vogue and why all these things started important giving started importance. It all started in 2015 2016 when they started noticing this kind of scenario. So why? The reason is the risk of thr dislocation, and well done thr dislocation, the risk is up to as high as 8% with significantly increased instability. Why? Because of spinopelvic motion. This pathological spinopelvic motion, the risk increases up to 8%. The dislocation rate for normal THR or non-spinopelvic pathologies is about 0.3 to 0.5%. Okay. Whereas with pathological spinning, the risk increases significantly as much as 8%. And another important finding is whenever you see a chronically a degenerative hip, the degenerative hip can be for many reasons, right? It can be traumatic, it can be idiopathic, it can be rheumatoid arthritis, it can be ankylosing spondylitis or anything. Most of the times, that hip is always associated with spine pathology. Live about a normal degenerative hip. I'm speaking about, for example, post-birth sequelae or a Tom Smith arthritis. The patient must have had that arthritis or tuberculosis somewhere when the child he was in the child toddler group. But when the patient you have planned for surgery, THR, they are easily about third or fourth decade of their life, right? So over a period of 30, 40 years, there develops a degeneration. That degeneration coexists with your hip, spine and hip, the degeneration coexists. And this degeneration is up to 3.5%. Imagine what the result is, somewhere about 25 to 27% increase in the risk of your hip going for dislocation. A well done THR, a well placed cup, a well placed stem can still go for dislocation. That is the reason this topic has been gained a lot of importance in recent times. So let us understand each one by step by step. Very simple. I made it very simple. Okay. Let us understand few steps. First step. Okay. We make it call it as an anterior pelvic plane. Okay. We call it as an anterior pelvic plane. Simple. What is anterior pelvic plane? Okay. This view is a lateral view, right? this view or lateral view. How do we draw a anterior pelvic plane? We have to draw 3 or 4 parameters. Okay, we are supposed to draw 3 or 4 parameters. Let us draw one parameter, that is anterior pelvic plane. Anterior pelvic plane in the sense where, what is the most anterior part of your pelvis? Can anyone tell me what is the most anterior most part of your pelvis? It is ASIS, right? What is the most anterior part of the lower pelvis? It is your symphysis pubis. When you join a line between the two midpoint of the ASIS and the symphysis pubis, this plane is called as anterior pelvic plane. Any doubts? Okay, this pelvis, anterior pelvic plane. So how do you make it an anterior pelvic plane? First, which is the most anterior-most structure of our pelvis? It is ASIS. Okay, and which is the most anterior-most structure in the lower pelvis? It is pubic symphysis. When we join a line between these two, this is known as anterior pelvic plane. Understood? Okay, pubic symphysis. Yes, pubic symphysis. PS stands for pubic symphysis. Okay, that is your anterior pelvic plane. Next comes is your understand what happens. This pelvic can rotate anteriorly or it can rotate posteriorly. This pelvis can rotate anteriorly or posteriorly, right? Okay. How, which is the axis of rotation where the pelvis can move up and down? Okay, which is the axis of pelvis which it can starts moving up and down, up and down? This is around your hip joint. Okay, this is your hip joint. This is where your pelvis starts rotating either anteriorly or posteriorly. This, if it tilts posteriorly, we call it posterior pelvic tilt. If it tilts anteriorly, we call it anterior pelvic tilt. Okay, this is fixed. The rotation is happening around your hip joint. Agree? Two things you have to understand: anterior pelvic plane and this center of one femur head, center of second femur head. So we call it as a bifemoral coxa or coxa femora axis. Okay, we have two femurs, coxa is head. That axis is called as bifemoral coxa axis. Okay, along with that, either the pelvis can move up or it can move back.